Researchers at the Duke Center for Applied Genomics and Precision Medicine recently made headlines with a blood test that could help doctors distinguish between a viral and a bacterial infection. The test is now poised to help reduce the overuse of antibiotics. It's also part of a much larger effort by the Duke team to rapidly and accurately diagnose infections based on a genomic characterization of a person's response to infection. We're talking with infectious diseases physician and researcher Chris Woods about the effort, the progress they've made, and what's next. Dr. Woods, thanks for being here.
Pleasure. Thank you, Kendall.
When most people think about diagnosing an infection, they probably think about something they're familiar with, like a strep test, where you'd be swabbing the throat and looking for the presence of strep bacteria. When did you start to think about tackling the problem of infectious disease diagnosis from the other end based on an analysis of the host's response?
I've been trained as an infectious diseases clinician and also as a medical microbiologist. So taking care of patients with infectious diseases as well as working on diagnostic tests to help identify the types of infections they had. And so I developed early an appreciation for the importance of improved diagnostics. And we spent a lot of time trying to do epidemiological studies with these limited pathogen-based diagnostics, and oftentimes only identifying an etiology of an infectious syndrome about 60% of the time at best, and that's with using very aggressive, the best case scenario for different diagnostics that would be available. Oftentimes when hunting for the pathogen, there may be limited numbers of bacteria or virus or parasites still present to identify. And depending on the stage of the disease that you're identifying the patient or bringing the patient in or when they present, it is entirely possible that the amount of pathogen available to detect is so limited that even your best molecular diagnostics would not be sufficient. So we thought early about the opportunity to harness the host response as a means to complement those pathogen-based diagnostics. So our first project was during my fellowship in the early 2000s, and I worked in Nepal. So actually, the very first host response, or at least transcription-based response diagnostic work with human infectious diseases was done in a bathroom closet in Nepal in a small hospital there, which is probably pretty amusing to most people. It was a very successful project as a preliminary project, but we were limited in what we were able to achieve through this, what I'll call a pilot, due to our ability to handle the large amount of data that were generated through these microarrays, and the data and the analytic techniques had not been fully developed at that point. So things went quiet for a few years at that point, and we let the technology catch up.
What's been so important to the success of the effort, I think, at Duke is this multidisciplinary team you were able to put together. So you've got yourself, expertise in infectious diseases, Jeff Ginsburg, who had the expertise in genomics, and then Larry Karen, who is an expert in computational analysis and engineering. How'd you get this team and this program together?
And so I was very lucky to get together with Jeff Ginsburg and Dr. Karen on a project that we became aware of through the DARPA, the Defense Advanced Research Agency, and they had put out a request for proposals related to a particular idea called predicting health and disease. One individual in a battalion or some other group of warfighters became infected. Could we predict who would go on to become ill. And that fulfilled this notion of predicting health and disease. So our approach in responding to this request for proposals brought together myself, Jeff, and Dr. Karen, as you say, in a multidisciplinary way, which is a wonderful part of the environment here at Duke, as those types of relationships are really fostered. And we got together and suggested a more or less a two-pronged approach to the question. The first was based on initially doing a single respiratory viral challenge in otherwise healthy adults. So in total, we performed through that project, seven separate respiratory viral challenges. And we were able to demonstrate that we could not only detect a signature for when someone was sick, and it was slightly different when it would occur based on which virus was being used, but we could push that signature back in time and actually 1 to 2 days after exposure predict who would go on to develop a symptomatic disease. And that fulfilled the request that DARPA had sought from us to fulfill, that we could do this pre-symptomatic program. Now, the second part of the program we put together allowed us to validate this respiratory viral signature. And the question is, how do you actually identify people who are going to become ill in a real life setting? At Duke, the closest thing we have available to us is here on campus. We have these dorms. Barracks dorms, they're fairly interchangeable. It's usually people about the same age, 18 to 22. And so we set up a prospective cohort where we monitored these students, principally freshman students. So we used this index cluster model is what we called it. And we would go and we were able to, after doing this sequentially for several years, including during the H1N1 outbreak pandemic during 2009, and we could validate this viral signature, what we call a pan-viral signature, because it works across several respiratory viruses that I mentioned, and validate that in this unique college cohort. And so that was our first real successful experience here. Again, generating a signature using this very robust model of a human challenge model, and then taking it out into the field and validating it in a real life cohort.
So at that point, you had this signature of a viral infection in hand, but you still couldn't really rule out that a person might also have a bacterial infection. Was that a tougher problem to solve?
And most of those who work in acute care settings, emergency rooms, really felt that having a bacterial signature was important, so you could rule out the presence of at least a bacterial infection that may be occurring concurrent with a viral infection. So our approach here was slightly different, and we went into our emergency rooms and actually recruited individuals into a larger cohorts through our through identifying people who presented with respiratory symptoms, so people who had cough or fever or shortness of breath. And we looked, we would then use adjudication methods where we brought in expert clinicians to review diagnostic data and clinical presentation to assign an etiology, be it a viral etiology, a bacterial etiology. And in many cases, there was no infection present, and they had some alternative cause for their symptoms, like a pulmonary embolus or a heart attack or heart failure, those types of presentations. And we've been very pleased and have been very successful in both generating new viral signatures, a new bacterial signature, and a signature for non-infectious processes. And we using this cohort, we're able to generate these 3 different probabilities and assign a diagnosis or a likely diagnosis to each individual based on those probabilities. And this is really the first type of diagnostic of its kind.
So these signatures that you now have to distinguish bacteria versus a virus seem to be very practical for use in the clinic. What will it take to get them into a form that a doctor might actually be able to consider using?
Here we were developing a combined viral bacterial signature, which has a goal of reducing inappropriate antibiotic use and encouraging, when appropriate, antiviral use. So the goal here is to really influence clinical decision making. So we needed to generate a diagnostic test, or put this assay that we had developed onto a diagnostic platform that could become useful to a clinician. So we successfully transitioned the viral signature initially over to an RT-PCR platform, and that platform, though, was still slow. So we successfully made the transition and and validated that signature and its new assay in kind of a free living cohort of individuals presenting to the emergency room. So that was the first step. But we still weren't able to turn around the assay in a real-time way. It still took 10 to 12 hours. And when we're dealing with a population who's coming in with these acute complaints, they're looking to get in and out of an emergency room or that situation. They need a result much more quickly. So what we have, with some funding we received through the Antibiotic Resistance Leadership Group, the ARLG, which has part of its headquarters here at Duke, we received funding to translate that RT-PCR assay to a novel platform, and that could turn the result around more quickly. And so that funding was made available. We've made great strides in converting that RT-PCR to this new platform. We'll see where that development continues to go. We're very excited about it. We have additional funding that is being used that has also come from DARPA, where we're looking at other platforms with handheld, that allows our assay to be in a handheld near patient platform as well. Again, our goal is to push this out as close to the patient as possible. So we're excited with those diverse partnerships. Our teams are there. It's just a wonderful relationship, wonderful group of partners, and that this whole diagnostic program has moved ahead better than we could have thought at this time last year.
Right. So what's been the best surprise for you along the way?
We always had said for the 10 years preceding of this program that if we build it, they will come, and we meant that from a technological perspective. A number of colleagues were wonderful to work with, and that's been the biggest and most exciting part of this whole story has been that most recent recognition that we have a platform that allows us to propel forward in such a positive way.
Dr. Woods, thank you so much.
My absolute pleasure, Kendall.